Well, we undertook this study to try to determine what are the limitations. And what we discovered that first, we don't want to be overly critical. I mean, the USPSTF was putting together guidelines with available information in order to try to facilitate identification of patients at risk for preeclampsia and their subsequent prophylaxis with aspirin. Our study was the first time it was actually used in a single population, in a large nationally representative population. And what we discovered was that basically 89% of the population is at risk for preeclampsia, has at least one moderate or high risk factor. And our concern is that if 89% of the population is at risk, it's going to be very hard to be personalized and individual about the approach to prophylaxis. And there may be a tendency to, um, if everybody's at risk, maybe nobody's at risk. So it might not be as effective as had originally been intended. Well, I think the steps are going to be manyfold. First of all, USPSTF is not the only group who's put out guidelines. The ACOG has similar set of guidelines. The NICE group in the UK also has a similar set of guidelines, and they're really not horribly different. I think looking at individual characteristics, clinical characteristics, is probably not informative enough. And I think ultimately what we may need to do is employ markers that are based on the biology of the patient. If you look at markers for risk factors for cardiovascular disease, say, and other conditions, there are individualized markers such as cholesterol or high density lipoproteins that are used to scale risk. Pregnancy doesn't really have those markers yet, and I think moving in that direction is really what's going to help us to make recommendations for prophylaxis and therapy much more specific. Well, that's a big, big topic. And what our study has shown, and what some of our other papers have also shown, is that there is no inherent tendency to be just by a patient being Black to be at risk. And let me be quite clear what I mean by that. In our study, if you take out the high risk factors, what you find is that maternal race really isn't that informative. And that is to say that there's likely to be an overrepresentation of high risk factors due to systemic racism, due to a lot of other characteristics that are um, inherent, unfortunately, in our society. These high risk factors are more likely to be more prevalent in the Black population. If you remove those high risk factors, race does not become a very informative variable. And we interpret that optimistically. It means that we need to treat the individual rather than treating a label or a social assignment. I think research down the road is going to need, as I said earlier, to look at biologically specific variables. Our group has worked with cell-free RNA. MIRV's platform is optimized to look at cell-free RNA, and we have a test that's actually available to stratify risk for preeclampsia. I think what that work is showing us is that, first of all, preeclampsia is a very complicated disease. We have labored under the idea that it is one condition for a long time, and that was really just a statement about our understanding of the underlying physiology or pathophysiology. Now we're developing better tools for really understanding the underlying pathophysiology. Some of our work has demonstrated that there is an earlier version of preeclampsia up till about 35 weeks that is associated with placental dysfunction, and a later version that is associated with immune activation. And interesting, the later version is statistically indistinguishable in our analysis from gestational hypertension. So it's suggesting that there may be, not maybe, that there are subtypes of preeclampsia, and that being specific about therapies designed for these subtypes is really going to be the way forward. We need to, rather than grouping everybody all into one category, try to pull it apart and see who's going to benefit from what therapy within what subgroup. I think one of the important things to understand is that the status quo hasn't been working. That we put out guidelines and checklists for different characteristics, and it really hasn't brought about a decrease in the prevalence of preeclampsia. In fact, if you look at national statistics, the rate of preeclampsia is increasing. And this is concerning because the rate of preeclampsia is increasing at a very time when staffing issues for obstetrical care providers are becoming more acute, and there are an increasing number of obstetrical care deserts within the U.S. So this is probably a first pass at trying to become more active in how can we stratify risk and how can we get patients around some of these obstacles, care deserts, decreased staffing, and move them into more effective care environments.